Assalamualaikum and a very good morning to all my students. Today I'm going to show you the examination of the breast. For adequate exposure for breast examination, you should expose the patient where you should see both the shoulders, the axilla, the whole of the bilateral breast until the level of the umbilicus. Now I'll show you how to do the examination of the breast. Start with inspection. First, start inspection from the nipple. After that, go to the areola, the whole breast, and after that to the axilla. When you want to see at the axillary part, you ask the patient to raise up the upper limbs and put the hands below the head. You're going to see whether there is a prominent swelling at the axilla, as well as to see whether there is a changes on the breast when you raise the hands up. Lastly, inspections also involve looking at the area of the supraclavicular area. This is the example how do you describe during inspection. Let's imagine that this patient comes to you with history of a swelling on the left breast for 6 months duration. During my inspection, I can see the nipple situated symmetrical in line. There is presence of bloody discharge on the right side of the nipple. Both the areola looks normal. However, there are presence of skin dimpling at the upper outer quadrant of the left breast. There's a presence of peau d'orange on the lower outer quadrant of the left breast. Otherwise, the other side of the breast looks normal. On the right side, there is a presence of skin hyperpigmentation with reddish spot on the right lower outer quadrant of the breast. When I ask the patient to put the hand behind the head, there is no swelling seen at the right and the left axilla. Upon lifting up the hand behind the head, there is no changes in terms of the line of the nipple. Okay. There is no obvious swelling seen at the supraclavicular region. If the swelling is attached to the skin, you will see the nipple line won't be symmetrical when the patient lifts up the hand. Again, the lesion will be retracted up because it will be pulled by the skin. Next is palpation. You should start your palpation by examining the normal breast. Why it is so? There are few reasons why you should examine the normal breast. Reason number one is to feel the normal texture for the patient's breast. Mind you that a patient to a patient, they will have slight different in terms of texture of the breast. Reasons number two, you shouldn't preoccupy yourself with a diseased part. You should start with a normal part so that you may have a higher chance to detect another lesion if it is possible. Reasons number three, if the sites of the lesion is contaminated or is a fungating breast lesion, you don't want to contaminate the dirty part to the clean part of the breast. Because of that, you should start with the normal side of the breast. First, palpate in circular motion from the inner upper quadrant of the breast, then a lower inner, then the lower outer, then the upper outer of the breast. Then go towards the axillary tail. Next, test for a nipple discharge by pressing on upper and lower part of the breast tissue going to the center to the nipple. and after that medial to lateral. Don't examine for discharge by pinching on the nipple. It is wrong. If there is no lump on the normal breast, you can either continue with the abnormal breast or you do the examination of the axilla before you go to the other breast. I will show you the examination of the axilla afterwards. So next, let's go to the other side or the affected breast. Again, similarly, start from the upper and inner part of the breast, then the lower part, the inner part of the breast, the outer lower of the breast, then at the end the upper outer of the breast going to the axillary tail. For this patient, I can feel a mass at the upper outer of the left breast. So, you should start to describe about the mass. For example, I can feel a mass which is around 2 times 2 in measurement. It is firm to hard in consistency, non-tender, it is mobile, it's not attached to the skin. There is no skin changes seen on the overlying skin above the mass. Let's say the mass is fixed or it is immobile. What should you do? You should continue with a test of fixation where you ask the patient to put the hands to the hip. Okay? Then, by doing this maneuver, you will contract the pectoralis major muscle. And if it is attached, the mass is attached to the pectoralis major muscle, it will be immobile during this maneuver. So, you should mobilize or test for the movement of the mass from the side. How does the muscle fiber of the pectoralis major go? So, you should go this way. If it is fixed on this way of examination, you should go to the other way of examination, which is upper and lower, up and down. If the mass is fixed during moving obliquely along the side of the fiber of the pectoralis major, but it is slightly mobile in upper and lower mobilization, it means that the mass is attached to the pectoralis major only. However, if the mass is immobile along the fiber of the pec major and also immobile on upper and lower movement, means it go deeply infiltrating into the intercostal muscle. Okay, next, again, check for nipple discharge in 2 directions. And lastly, examination of the axilla. To examine the axilla, there are 5 quadrants or 5 sites that you have to examine, where the axillary lymph nodes are divided into apical region, central region, anterior region, posterior region, and lateral region. So, how should you examine the axilla? There are few ways, but I'll show you one of the method. Okay. Let's say you want to examine the right side of the axilla. So, you take the left arm, the right arm, then support with your right forearm. Okay. Then after that, you lift up the upper limb and scoop inside. Then you bring the patient's upper limb down. You are actually palpating the apical region. Then from here, you go down a bit, then palpate for another region of the axillary lymph nodes, which is the central part. Next, go slightly to the front, just behind the tail of the pectoralis major, where you are actually palpating the anterior part or anterior region of the axillary lymph nodes. Next, go slightly lateral around the area of posterior axillary line, where you can find the posterior axillary lymph nodes. The last group is lateral part, where you change your hand again and palpate at the starting point of your upper limb, where it is a lateral part of the axillary lymph nodes. Do the same thing for the other side. Okay. Last but not least is examination of the supraclavicular lymph nodes. So what should you do is go to the back of the patient and examine the supraclavicular area. Don't forget to also examine the infraclavicular area. To complete the examination of the breast, you should complete with the examination of the vertebral spine and also the examination of the tenderness of the rib cage. Next one is examination of the abdomen to look for hepatomegaly. And the last one is examination of the lung to look for evidence of pleural effusion.
Good morning, everyone, and to the doctor. I want to ask a question. Usually, what is the best position to examine the breast?
Okay, good question. The position which is appropriate to examine the breast is either sitting up or in lying 45 degrees. Why is that so? Because with that position, the breast is following the gravity, so that you will see the nipple line whether it's symmetrical or not. When the nipple line is not symmetrical, it will give you an idea whether there is a presence of mass which is retracting the nipple up or down. What will happen if you put the patient supine? In general, it doesn't have a big problem. However, if the patient has a pendulous breast or a big breast, it will sag down laterally. It will make it a bit difficult for you to examine. And at the same time, it's difficult to determine the symmetrical of the nipple line. Is there any other question?
Good morning, sir. I have another question. How do we manage a patient with a breast lump?
Okay. In general, examination of the breast lump or managing a patient with a breast lump consists of 3 parts, or you call it as a triple assessment of the breast, which including clinical, imaging, and also histopathological examination. Clinical examination consists of history and physical examination. The imaging consists of either ultrasound or other imaging, for example, mammogram. And histopathological involve any tissue diagnosis by either fine needle aspiration cytology or a biopsy. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all my students. Today I would like to show you how to examine a stoma. Stoma examination is actually a part of abdominal examination, where the patient is put in lying supine as how you examine the abdomen. So before you start on examination of the stoma, you should finish the examination of the abdomen. Yes, there is some restriction of examining of the abdomen if you have a stoma bag around a certain area. Don't worry. Just examine the part which is not covered by the stoma. If you see this a model, you can see a bag which is put on the left side of the abdomen. There are 2 types of stoma bag. The one which is provided to you today is the one which is transparent, where you can see a bowel wall or a mucosa of the bowel being put out or being created out to the abdominal wall. However, in some occasion, you will have a stoma bag which is non-transparent. So, it's difficult to you to say during inspection that it is a stoma behind the covered bag. So, to start the examination of a stoma, you should inspect and show what is other things which is seen during your inspection. Mind you, sometimes you will see stoma only during inspection, but sometimes it also comes with a midline laparotomy scar. Example of inspection for this patient towards a stoma sounds like this. On inspection of the abdomen, I can see a drainage bag on the left lower quadrant of the abdomen. And it is a transparent bag where I can see there is a stoma below or behind the drainage bag. The stoma is created flush to the skin. The content of the bag consists of a fecal matter, which is solid. There is no skin excoriation seen around the stoma, and the stoma looks healthy. There is no gangrenous spot, there is no bleeding point, and I can see a single lumen during my inspection. However, I will confirm it again when I open up the covering bag. Let's say it is a non-transparent bag where you cannot see the structure behind the drainage bag. So the inspection sounds like this. On inspection of the abdomen, I could see a drainage bag. However, I didn't know what is the structure behind the drainage bag. So I will confirm it back during my further inspection when I open the covering bag. The covering bag situated at the left lower quadrant of the abdomen, and it is full with a gas or with a content which I can feel it is slightly fluidy. There is no other scar seen on the abdomen. And for further examination of the structure below it, I will after this expose with by opening the drainage bag. Okay. Before you open the drainage bag, make sure you are well prepared with a pair of gloves and also some gauzes. Okay. Once you open the covering bag, please inspect and explain again to your examiners or to your respective lecturers. Okay. When I open the covering bag, I can see a stoma where it is created flush to the skin. There is no obvious skin color changes seen around the stoma. There is no gangrenous patch. There is no hyperemic area. There is no bleeding point seen. The skin around the stoma looks healthy. There is no excoriation. As far as I can see, there is only a single lumen opening. However, I'll confirm it again during my palpation. Before you end your inspection, ask the patient to cough. Encik, boleh saya minta batuk ke? Okey, terima kasih. If there is a parastoma hernia, you will see a bulge coming out around the stoma. Okay. In this patient, the cough impulse is negative for parastomal hernia. Next, continue with your palpation. Wear a pair of gloves and start palpating from outside going inside. Why is that so? You will less contaminate the content from the stoma going to the surrounding skin. Okay. So, palpate around the stoma to feel for any evidence of tenderness, which may indicate evidence of infection. For example, a parastomal abscess. Then, palpate on the stoma to look for any evidence of contact bleed. And at the end, you should see around the stoma to look for any evidence of a skin infected or abscess around the stoma, again for parastomal abscess. Next, ask permission from your lecturer or your examiner to examine the lumen of the stoma. What should you do is take a Vaseline gel or a lubricant gel and put your finger inside the stoma lumen. Sometimes there is a double lumen stoma and the other one is actually created just below the stoma that you've seen. So please see it carefully. It's important for you to know how many lumen do you have on a stoma, because it will tell you how the stoma is created. At the end, before you finish, you should see whether the stoma is functioning or not by seeing the content, and also if you want to look for the general abdomen to look for bowel sound.
Okay, good afternoon, doctor. How do we classify the stoma?
Okay. When you are given a task to classify a stoma, you should know that stoma should be classified in various ways. There are three ways how do you classify stoma. Number one is based on location. Okay, stoma usually created based on the mobility of the bowel. If the bowel is mobile, it is preferable to create a stoma. It is not created on a fixed part of the bowel. Okay, for example, if the stomach located at the left lower quadrant of the abdomen, it is usually a sigmoid colostomy. If it is somewhere around the right upper quadrant of the abdomen, it is a transverse colostomy. Rarely you will see a cecostomy. Yes, cecum is a structure which is mobile, but creating a cecostomy usually create more complication. Thus, usually people won't create cecostomy nowadays. But you will find another stoma which is usually located around a right lumbar or right iliac fossa region, which is your ileostomy. The second way of classifying stoma is based on how it is designed, whether it is a single lumen or end colostomy, or it is a double barrel colostomy, or it is a loop colostomy. The third way of classifying stoma is based on its function, whether it is temporary or it is a permanent. Permanent colostomy usually is an end colostomy or a single lumen stoma, whereas the temporary colostomy usually either double barrel or loop colostomy. Okay, can I get a second question?
Good afternoon, sir. What are the complications of the stoma?
Okay, stoma complication usually being divided into either it is an early complication or a late complication. Example of early complication is a stoma gangrene because of a poor blood supply. A stoma can be prolapse. There is a parastomal abscess, and sometimes you can have an early parastomal hernia. In a case where a stoma is not well performed, especially when the cutting of the rectus sheath is small, you can get a stenosis stoma. For late complication, you can have again a prolapsed stoma, a retracted stoma, parastomal hernia, and disuse atrophy of the distal part of the stoma, where usually the distal part of the stoma or the distal lumen is slightly smaller because it is not used because of the fecal diversion. Can I get the last question?
Good afternoon, doctor. My question is, if there is presence of midline laparotomy scar and also presence of single lumen stoma, how do we know that it is Hartmann procedure or abdominal perineal section?
Okay, it is difficult to tell from the abdominal inspection whether the end stoma at the sigmoid area is a stoma from Hartmann procedure or it is a stoma from an abdominal perineal resection. However, there is a slight difference in the other part of inspection. You should inspect around the anus, where in abdominal perineal resection, as the name is abdominal and perineal, means there is two way of operation. One is abdominal part, where they resect the tumor and create a stoma, and the other one is perineal resection, where they also do a resection from the perineum going to the tumor. Then at the end, they will close the anus. So for stoma in abdominal perineal resection, the anus is closed, whereas in Hartmann procedure with a stoma, the anus is still patent.